somewhere tonight, an American family is opening a hospital bill for $1,300. They still have health insurance. Somewhere else, a family in Japan just walked out of a hospital owing nothing at the register. Same industry, same night. Two completely different bills. So what exactly are those Americans paying for? Hold that question for a moment, because the number underneath it is bigger than either family realizes. The United States spends $4.9 trillion a year on healthcare, according to the Centers for Medicare and Medicaid Services National Health Expenditure accounts, more than the entire annual economic output of Germany and Japan combined. Spread that across the population, and it comes to roughly $14,600 per person. That's nearly double the average across other wealthy nations, according to OECD health statistics. And here's the twist that makes the $1,300 bill sting even more: that grandmother in Japan will likely outlive her American counterpart by roughly 6 years. More spent, less life to show for it. For this episode, we're going to call that gap between what Americans pay and what they get back in actual health the American health premium. It's a term coined for this analysis, not standard economic jargon, but it's a useful shorthand for the extra money spent on outcomes that are often no better and sometimes worse than countries paying half as much. The easy explanation? Americans are simply older, sicker, or living rougher lives than everyone else. Except the data says close to the opposite. The US population skews younger than Japan's. And it still pays vastly more per person for care. So today we're asking 4 questions. First, how big is the American health premium really once you set it next to the rest of the developed world? Second, how did it get this enormous? Third, who actually pays for it once you look past the headline number? And finally, what breaks if this trajectory doesn't change? This isn't an abstract accounting exercise. Most Americans get insurance through an employer, which means every layoff is also a potential lapse in coverage. The U.S. unemployment rate sits at 4.1% according to the Bureau of Labor Statistics Employment Situation Report. Modest on paper, but each point of that figure is also a rough count of households one bad quarter away from losing their doctor. Overall inflation, meanwhile, has cooled to around 3% as of 2024, according to the Bureau of Labor Statistics Consumer Price Index. Healthcare costs did not get that memo. Premiums and hospital bills keep climbing well above that headline rate, while paychecks for most workers barely move. That widening gap is the entire episode. It just takes some unpacking. Start with scale. National health spending reached $4.9 trillion in the US in 2023, according to CMS's National Health Expenditure accounts, 17.6% of the entire American economy going to healthcare alone. Peer nations spend closer to 9.6% of GDP on average, according to OECD health statistics. Per person, Americans spend roughly $14,600 a year. Comparable wealthy nations spend closer to $6,650, according to OECD health statistics. The United Kingdom spends about $5,900 per person for a full national health service. Canada spends about $6,300 for universal coverage, according to OECD health statistics. A routine appendectomy runs roughly $33,000 in a US hospital and closer to $6,000 in France for the identical procedure, according to the International Federation of Health Plans. And the return on that spending is thin. Life expectancy in the US sits at 76.4 years, against a comparable nation average of 80.3, according to OECD health statistics. Germany spends about 12.7% of its GDP on healthcare and still posts a life expectancy near 81 years. A smaller share of the economy, a longer life. You'd fire a contractor over that math on a kitchen renovation. But scale alone doesn't explain the premium. It tells you the bill is bigger, it doesn't tell you why. The real culprit is how American hospitals set prices in the first place, and that story starts in the billing department, not the operating room. Start with the plumbing. In most wealthy nations, a government negotiates one price for a given procedure, and hospitals charge close to that number nationwide. In the United States, there's no such thing as one price. A single MRI scan can run $1,420 at one hospital and $450 at a clinic 10 miles away, according to the Rand Corporation's Hospital Price Transparency Research. Multiply that unpredictability across an entire economy, and administrative overhead alone runs near 8% of total U.S. health spending, compared with 1 to 3% in single-payer systems, according to Health Affairs. That gap accounts for hundreds of billions of dollars spent not on care, but on paperwork. Nobody designed it this way on purpose. It just kept accumulating, one billing department at a time. Here's a case worth sitting with for a moment. A single American patient, healthy, mid-30s, needed a routine knee arthroscopy. Same knee, same tier, as a friend treated the same year in Madrid. His American bill, $19,000 at one hospital, though a second hospital across town quoted $35,000 for the identical implant, according to Healthcare Cost Institute pricing data. His friend's bill in Spain, about $8,000 according to the International Federation of Health Plans. Same injury, same fix. A $27,000 spread that has nothing to do with medicine and everything to do with geography and negotiating leverage. Picture a supermarket where nothing on the shelf carries a price tag. You fill the cart, you eat the food, and only afterward does a bill arrive. A different bill depending on which checkout lane you used, whether you had a membership card, and whether the store quietly decided to waive part of it that week. That's roughly how American hospital pricing works. Every insurer negotiates its own private rate. Every hospital keeps a list price, called a charge master, that almost nobody ever actually pays. There's a name worth coining for the cost of running that supermarket, the complexity premium, a term coined for this analysis, describing the extra money spent not on better medicine, but on simply navigating a system built with no visible prices. Drug pricing runs on the same logic. Americans pay on average about 2.6 times more for identical brand name prescription drugs than patients in other wealthy nations, according to a Rand Corporation International Drug Price Comparison study, largely because the US government does not negotiate a single national price for medicine. Pharmacy benefit managers collected an estimated $315 billion in rebates and fees in 2022, according to the Berkeley Research Group. Hospitals have also consolidated hard over the past 2 decades. Fewer systems, larger networks, more pricing power, and prices have followed the consolidation, not the other way around. None of this is illegal. It's simply expensive by design. The number that explains who actually absorbs that complexity premium is 41%. That answer is in the next section. On paper, the bill looks split 3 ways: employers, government, and patients. In practice, employers pass their share straight through. The average annual premium for family coverage through an employer now runs $23,968, according to the KFF Employer Health Benefits Survey, and the worker's share keeps rising faster than paychecks. The average deductible for an employer health plan now sits at $1,735, according to the same survey, more than double what it was a decade ago. Wage growth for most households hasn't kept pace with medical inflation, even as headline inflation cooled to around 3% in 2024, according to the Bureau of Labor Statistics, while the top 10% of earners captured nearly a third of total income, according to Census Bureau income statistics. The people best insulated from rising premiums are concentrated at the top of that distribution. Everyone else feels it at the shrinking paycheck. That is not an accident of timing. Follow the money one layer further and the picture gets more personal. At the bottom of the ladder, some people simply go without. The Census Bureau counts roughly 25.6 million Americans with no health insurance in a given year. For many of the rest, coverage exists, but the bill still lands hard. Roughly 41% of insured adults report carrying some form of medical debt, according to KFF's Healthcare Debt Survey. That's the number the last section deferred. 41% of people who did everything right, paid their premiums, kept their coverage, still end up owing money they didn't expect. A widely cited 2009 study published in the American Journal of Medicine estimated medical debt was a contributing factor in as many as 62% of U.S. personal bankruptcies, a figure later disputed, with subsequent studies putting the true share anywhere from under 5% to well over half, depending on methodology. Even the low end of that range is higher than in most peer nations, where a routine hospital visit rarely ends in a bankruptcy filing at all. That's not a footnote. That's the system working exactly as built, just not for the person holding the bill. Somewhere behind that 41% is a family staring at a bill it never priced in advance. Which brings us back to the one opening this episode. Zoom out to the federal budget and the trajectory gets worse before it gets better. Medicare and Medicaid together cost the federal government about $1.5 trillion in fiscal year 2023, according to CMS budget data. The Congressional Budget Office projects that combined bill will reach roughly $2.3 trillion by 2033, growing faster than the economy that has to fund it. Total federal debt held by the public has already crossed $28 trillion according to the U.S. Treasury, and national health spending overall is forecast to reach $7.7 trillion by 2032, according to CMS's National Health Expenditure projections. Interest payments on the federal debt are already competing with healthcare spending for the same shrinking slice of the federal budget. Eventually, something gives, taxes rise, coverage shrinks, or the debt keeps absorbing the difference. Washington has mostly chosen a fourth option, defer the conversation entirely. That is not a strategy. It is a delay. It would be easy to end on that number and leave the picture bleak. But a few places have already shown this isn't an unsolvable problem. Maryland has run its hospitals under a state-negotiated all-payer rate system since the 1970s, capping what any hospital can charge regardless of insurer. Its per capita hospital cost growth has consistently trailed the national average, according to CMS evaluations of Maryland's all-payer model conducted with Johns Hopkins researchers. Singapore spends about 5% of its GDP on healthcare, roughly a third of the American share, while posting a life expectancy above 83 years, according to World Bank and OECD health data. Rwanda pushed national health insurance coverage above 90% of its population, while spending less than $60 per person a year, according to World Bank health financing data. Colorado's state-run reinsurance program has cut individual market premiums by roughly 20% since 2020, according to a Colorado Division of Insurance Analysis. Germany's all-payer negotiation has kept administrative overhead near 5% of total health spending, less than a third of the American figure, according to OECD health statistics. Every one of these systems proves the same point the supermarket analogy already made. Visible prices bend cost curves faster than hidden ones. And the complexity premium shrinks the moment somebody can actually see the number before they buy. Which brings us back to that $1,300 bill. It landed on that family's counter because the hospital could charge it without ever publishing the price in advance. A chargemaster number, negotiated in the dark, no different in kind from the $19,000 knee or the $1,420 MRI scan discussed earlier. That is the complexity premium arriving in an envelope. Federal price transparency rules, in effect since 2021, have already pushed roughly 80% of hospitals to post at least some negotiated rates online, according to compliance audits from Patient Rights Advocate. That's the same visible shelf pricing that already works in Maryland and Singapore, now arriving, slowly, imperfectly, in ordinary hospital billing departments. Once a price is posted before the procedure, that family can compare it, question it, negotiate it, or simply choose a different provider. The bill doesn't vanish, but it stops being a surprise. And a $1,300 surprise, priced in advance, tends to shrink. The American health premium isn't physics. It's policy, built one negotiated contract at a time, in the dark. And policy can be rebuilt the same way in the light. The most likely path forward is incremental: more price transparency rules, more states experimenting with rate setting closer to Maryland's model, more pressure on drug pricing at the federal level. That won't cut the bill in half by next year, but it could plausibly bend the curve enough that per capita spending stops outrunning wages within a decade if current transparency reforms actually hold. The family that opened this episode isn't stuck with today's prices forever. The costs are hidden, not fixed. And somewhere, that's already starting to change. Thanks for watching. Mind your reserves. This video is for educational purposes only and is not financial advice.